Good afternoon, and welcome to the last session of a terrific first day, Managing Pain with Chronic Kidney Disease. The information shared in this session is not intended to be medical advice. We recommend always that you speak to your doctor and care team about your individual situation. Good afternoon. My name is Craig Lindsay, and I'm joining today from Toronto, where I serve as the Director of Programs and Public Policy with the Ontario branch of the Kidney Foundation of Canada. It is my pleasure to welcome you to today's session on managing pain with chronic kidney disease. Pain is a common yet often overlooked symptom of chronic kidney disease, renal failure, and the transplant journey. It can lead to emotional distress, insomnia, missed treatments, impacting overall health and quality of life. I hope we learn that effective pain management can improve patients' adherence to treatments, improve the quality of life, reduce healthcare costs, and ultimately enhance overall health outcomes. Having early, open, and honest conversations about pain can help CKD patients and their families maintain a better quality of life. We are pleased to welcome here today a panel comprised of those with both medical expertise and lived experience of managing a life with kidney disease. Our focus today will be on the symptom of pain. Let me start by introducing today's panel. Next slide, please. Dr. Tabo Sikaneta has worked as a nephrologist and researcher at the Scarborough Health Network, one of Canada's take the slide down, please. Dr. Tabo Sikaneta has worked as a nephrologist and researcher at the Scarborough Health Network, one of Canada's largest and most ethnoculturally diverse dialysis programs since 2004. He is also medical lead for the Toronto region of the Ontario Renal Network. Dr. Sikaneta, can you start with a few quick words about why you see the subject of pain as a symptom in kidney disease worth exploring? Why does it matter?
Okay, well, good afternoon, Craig. Good afternoon, panelists. Good afternoon, everyone in the audience. Thank you for the warm welcome and for inviting me to speak today. Pain is definitely worth exploring for a number of reasons. One, it's surprisingly common. In fact, even for me with a lot of gray hair, having worked in this business for long enough, in preparing for this talk today, I did formal reviews of the literature on just how common is pain. I looked at study after study, and I was surprised that about half of our patients who are on dialysis have kidney disease. It's certainly much less than I would have guessed if you were to ask me to guess, and I would hazard if you were to ask some of my colleagues to guess, we wouldn't come up with 50%. It showed that for a couple of reasons, perhaps one, certain patients are perhaps not comfortable or willing to step forward to say they have pain. But more importantly, secondly, I think we healthcare professionals and kidney care professionals particularly don't do a good job of eliciting pain. We do our rounds, we see patients, we refill meds, we adjust the dialysis prescription. We don't give pain the attention that it requires, and we don't formally ask about it. We don't actually grade it. We don't get any kind of meaningful information. And so the studies that I found showed that when you do that, when you do formally elicit pain, half of our patients have pain. So to answer your question, I think it's worth exploring because it's very common. And something needs to be done about this.
I hope this conversation today goes a long way to helping people feel it's comfortable to address the subject of pain. I'd like to introduce Kristin Cuttress. Kristin is a caregiver and a parent of a 13-year-old girl, Lily, who had a kidney transplant 3 years after a year and a half on dialysis. After transplant, her FSGS recurred. Lily is currently followed by many clinics at the Children's Hospital of Eastern Ontario, including the complex care and chronic pain clinics. Lily has daily pain that has not directly been linked to her kidney disease, but she did not suffer from frequent pain prior to her diagnosis. She has 4 to 6 migraines a week, leg and ankle pain, and this pain affects her daily life, her ability to attend school, and her mobility and stamina. Lily perseveres with the support of her family and continues to enjoy her favorite activities, including skating, roller skating, swimming, and gymnastics. Important to note that Kristin enjoys volunteering with the Ontario branch of the Kidney Foundation as a peer support volunteer and a virtual group facilitator, most notably with the remarkable Parents of Pediatrics support group. Kristin, can you come on screen and briefly tell me what role pain played in Lily's journey so far?
Thank you, Craig. So yes, Lily's journey with pain was actually part of her presenting symptoms at diagnosis. It was actually a little misleading because it was difficult to nail down that it was her kidneys because the presenting pain was severe migraines. Um, so she does have those migraines almost daily, and they're triggered by heat, exhaustion, and hunger. Managing her pain has been ongoing for the past 6 years, again, since her diagnosis. And her first admission on diagnosis was a 3-month admission. And that admission did require the help of the acute pain team at her hospital. And since then, she was referred to and is followed by the chronic pain clinic. Her legs and her ankles tire easily, and she has also broken a few bones without us knowing the cause of the breakage, only that the pain persisted until we did x-rays. Rheumatology, endocrinology, chronic pain, nephrology, neurology, and complex care are all part of her team now, and a lot of them are there to help manage the pain.
That's a whole lot of clinics she's part of. Thanks, Kristin, for introducing. And we will understand if you don't know much about kidney disease. Patients are complicated. It's never just one thing. Thanks for introducing us to Lily. Glad you're here. Dave Edgar, he grew up living with type 1 diabetes. He experienced significant neuropathy or chronic nerve pain, although no longer diabetic due to a kidney and pancreas transplant in 2004. Dave has successfully managed chronic pain for almost 20 years. He also volunteers with the Ontario branch of the Kidney Foundation as a peer support volunteer and a virtual support group facilitator. Dave, can you explain how did and does pain affect you in your day-to-day life? Is it any different now than it was before your transplant?
Well, thanks, Craig. Thanks for the questions. And um I'd like to explain, how it does affect my life from day to day. I'll preface my answer with this, like managing my pain, like from kidney disease through dialysis and transplant, if you go that route. It's different for everybody. So, what I've experienced is um, different than what maybe you would experience, for example. It's kind of like a box of chocolates. You never know what you're going to get. So, but for me personally, some days chronic pain and can significantly impact my daily life. The pain has changed over the last 20 years. In the early days of my transplant, I was active, working full time, traveled a lot. Now, 20 years into my transplant, um, at 68, I've encountered some other unrelated health setbacks. And so, the pain comes from all different sources, but primarily from, the kidney and the pancreas. I've lived with that for 20 years. So in various ways, it's affected my physical, my emotional, my social well-being. For example, there's physical limitations, and I'm sure we'll discuss this a little later on, emotional and mental health. There's social and relationship challenges that can come up from pain, work and financial impacts, lifestyle changes, and medication management is key to relieving pain, which I'm sure we'll discuss. But the second part of the question was, is it any different than before my transplant? Before my transplant, I had a lot of back pain when I was on, kidney failure and dialysis. Overall, I felt like crap, bone and joint pain, muscle cramps, And as Craig alluded to earlier, neuropathy from diabetes. I was a lifelong type 1 diabetic. And so that affected me big time. But after transplant, the only real pain that I've experienced over the last 20 years, on and off, or at the early stages, was incision pain, burning, tingling, some swelling, side effects from drugs. But the interesting part is that the diabetic neuropathy, it hasn't improved very much. So, on a scale of 1 to 10, I was at a 5 when I had my transplant. So I've always remained at a 5 ever since my transplant. It doesn't magically get better because I got a pancreas and I'm no longer diabetic. So, that's other than that, generalized pain, just fatigue and weakness and overall discomfort. Some days, other days are different. Thanks. Hopefully I can answer some questions later.
Yeah, that's great. Thanks, Dave, for that overview. Dr. Sikaneta, do we all experience pain the same way?
No, it's a good question. First of all, the different types of pain vary, as you can tell already from Lily's experience and Dave's experience. There's nerve pain, there are headaches, there are pains related to the dialysis procedure itself. So if you're on, for example, hemodialysis and you have a fistula, you might get needle pain. So just the root causes of pain would be different person to person, patient to patient. And then even for the same type of pain in different patients, it would be experienced differently. Pain, as has already been alluded to, often coexists with other factors that collectively impact somebody's quality of life negatively. So it can come along with depression, it can go along with anxiety, poor sleep, fatigue, and they all kind of work together to compound each other. And so depending on how much or how little of those other factors you have, the pain may have a less or more effect per patient. So the answer is no, it impacts people differently for a variety of reasons.
Okay, thank you. Kristin, I'm going to come to you in a moment, but there was a question posed while we have you, Dr. Sikaneta. How many of that 50% dealing with chronic pain are due to things other than kidney disease, say rheumatoid disease, osteoarthritis, fibromyalgia, and a whole complement of other conditions?
It's a good question. So one of the leaders in this field is Canadian, Dr. Davison from I want to say Edmonton. So she published a landmark paper about 20 years ago, one of the first of its kind. Previous studies had always looked at pain as part of quality of life assessments, and not as many had focused particularly on pain. So they'll say, as part of a questionnaire, it would include pain assessment, it would include anxiety assessment, depression assessment. So she was one of the first to focus entirely on pain and what are the different causes. She looked primarily at hemodialysis patients. So the caveat is this may be different in people with PD, people who have had a transplant, people who are pre-dialysis. But in this group of 200 odd patients, she found that the leading cause of pain had to do with musculoskeletal problems. So osteoarthritis and, oh, someone there. So osteoarthritis, osteoporosis, back pain, degenerative disc disease, none of which should, I mean, a very small portion of which should have to do with kidney disease directly. Kidney disease affects bone health, but a lot of these features are presumably unrelated to that. And, the fact that Dave felt a lot better after getting a transplant in certain aspects of his pain, it's very interesting. Like, why would you have MSK pain? It shouldn't theoretically be part of kidney disease, and yet it gets better when you get a transplant. So I guess the jury's out. Like, these are things that traditionally have or should have nothing to do with kidneys, but they're much more common in our patients. And if they get better when you have something like a transplant, maybe there is a connection.
Thanks. Kristin, I wanted to ask, being a parent of a young child with many ongoing issues, how did you help Lily open up and discuss pain? Like, how did you help her put words to it? I think even caregivers have a critical role to help people living with kidney disease understand pain, to have conversations. How did you manage that with Lily?
So I would say that took a lot of time. I would say we're still working on that aspect. She's not an extremely verbal child. So a lot of it is just knowing either yourself or knowing your kid. So we would watch for things like stopping eating. She does things like have warm baths for 3 to 4 hours a day, and we noticed a pattern between that and any kind of exertion. So say she goes skating one day, the next day she'll run herself a bath and sit in there and just keep running the warm water and running the warm water. She isn't able to verbalize that there's a connection between the two, but we can see the pattern. We have, of course, very early on, the pain scale was introduced to her. She does use the pain scale. We have an entire pharmacological plan related to the pain scale. And she also has worked with a variety of child life specialists and psychiatrists at the hospital. And some of that work has been around verbalizing pain. A lot of it simply comes down to like a thumbs down is a clear indicator. So yes, it hasn't been easy, Craig. Thank you.
Okay. And does this conversation come up in the virtual support group where other parents are talking about children possibly experiencing pain?
Yes, it's come up in the virtual support group. I've also attended conferences outside of the Kidney Foundation, and I've definitely heard from other families that their child has pain sometimes connected to dialysis. There's a lot of talk around PD pain. Pain on peritoneal dialysis and drain pain specifically, but there's also pain that's unexplained. So, like for us, we've been basically told that the pain is not related to the kidney disease, but it's hard to see it separate from the kidney disease because they presented at the same time. It could be deferred pain, I don't know. So again, there have definitely been other families that have relayed that they have pain either directly related or just simultaneously.
Thanks, Kristin. Dave, I'm curious, living for many years with chronic pain that comes and goes, where did you look for resources? Were you able to have open conversations with your care team? Did you search online? Did you try different things? Where did you look and what did you find helped, if anything?
A lot of times, Craig, it was, discussions with family at first on the different problems I was having with pain, and then I get together. I guess most 20 years I'm having a hard time remembering pre-transplant, but post-transplant, getting together with my transplant team and kidney team, discussing different pain medications, and because every pain medication, there's a side effect to it. So some of the resources I got from my doctor, nurse practitioner, uh, research, Dr. Google. There's 3 websites that I look at quite frequently, WebMD and Cleveland Clinic and places like that that are authoritative and has some good information. So, and once I get the resources and figure out sort of next steps, and then it's a situation of trial and error, what works and what doesn't work. And a lot of things work for me and some things don't work, and like everybody's different. So if I explained that, answered your question right.
Well, it certainly does. Dr. Sikaneta, I wanted to ask, there's a danger in treating pain aggressively with kidney patients, I'm sure. Um, how do you balance the need to manage pain appropriately, but not damaging perhaps the kidney function or complicating things for the rest of the body?
Yeah, well, the opioid epidemic doesn't help anything. It has made everybody more cautious about prescribing medications, and it's particularly problematic in patients with kidney disease because the presence of kidney failure makes certain drugs, including many of the opioids, more difficult to dose appropriately, more side effects, more challenges with it. So that's a big part of the problem. And then some of the other pain medications, such as like gabapentin or Lyrica, they too are altered by the fact that someone has kidney failure, and therefore their doses have to be adjusted. And so they may not be getting the doses that are as effective because of fears of overdoing it or because of fears of toxicity. And then in the pre-dialysis world, of course, all of the non-steroidal anti-inflammatory medications are essentially no drugs because they might exacerbate or precipitate worsened renal function. So the armamentarium is smaller. The options are fewer. We are more cautious because of the side effects. So it's more complicated, but there are effective drugs, or there are more effective drugs. There is more effective use of existing drugs. This is what I've realized in preparing for this, that we are not using. So because of this general fear, many of us just generally are hesitant. But there are some that have been shown to work, and it's really just a matter first of eliciting the fact that there is pain, which, as I said earlier, we healthcare professionals don't do a really good job at. We should do better at. And once it's found, there's a ladder. I think it was Kristin with Lily's experience was mentioning that there are like an algorithmic approach. It's from the cancer literature that's been adapted to our population. Therefore, the concerns about drug toxicity, et cetera, have been somewhat addressed. So it's out there. We just are not as aware as I think we should be.
Kristin, did you want to
May I
interject?
add? May I add?
Yeah.
I was going to say that something that we've run into as well, and it may be more the pediatric angle, but we've also run into access. So medication for pain and for other things, some of them are still in clinical phases. And even though her team has wanted to use them, it's been challenging because she won't qualify for the trials due to all of her comorbidities. But then accessing them with funding without them being completely approved. So has been challenging. So access has definitely been challenging, and funding, even though we're fortunate to have two private insurance companies, funding has been tricky for some of these pain medications.
Thanks, Kristin. Someone rightfully in the Q&A posed the question about non-medical or non-pharmaceutical treatment for pain, and we're going to get to that really soon. But I wanted to put it out, Dr. Sikaneta, when we first talked about this subject, you said there was a correlation between pain and the type of treatment people choose, whether it's PD or hemo, and a correlation between outcomes if pain. Am I paraphrasing that correctly?
I was giving you my anecdotal experience.
Okay.
And, the problem is there is not a lot of evidence one way or the other. It has been looked at. What are the differences between the different modalities? But the majority of the studies are on patients who receive hemodialysis. But definitely anecdotally, I can say that the patients who are on hemodialysis seem to have a lot more pain. It could be, of course, part of the challenge is that people who tend to go on hemodialysis are older, they have more comorbidities. For example, they may have more arthritis, or they may have more of the common causes of pain that go along with kidney disease, versus people who might get a transplant or who are on PD, who might be younger, more independent. So it's a little tricky to tease out. Is it the fact that the modality is different and causes it, or is it that the patients are different, the types of patients that choose the different modalities?
Okay, thanks for clarifying. Let's talk about it now, perhaps. Any of the panelists, Dave, Kristin, or Dr. Sikaneta, what about mindfulness, meditation? Someone also posed the question of First Nations cultural healing practices and procedures. There's more beyond simply medication. Anyone?
So we have part of our chronic pain team is a 3P approach. I'm trying to remember the 3Ps on the spot. I'm struggling, but it is a 3P approach. I believe it's physio, pharmacological, psychology. So they do look at all 3Ps, and that is part of our plan, especially when we're looking at things like the leg pain, the ankle pain, and coming up with a plan on the scale. So things like meditation, deep breathing, massage. We've done myofascial release. She has something called a cephaly machine, which is similar to a TENS machine, but for your head. Also have creams, done a little bit of essential oils. So all of those things, little hand massagers, all of those things, again, the hot baths, all of those things play a role in the overall plan for how we manage her pain. But I would say that we use most of those daily as well.
Thanks, Kristin. Dave, what about you? Does mental well-being and being mindful and present in the moment, was that of any value in your pain journey?
Well, it has, and to add to what Kristin was saying, there are some non-pharmaceutical treatments that have helped me with my journey, and physical therapy. I did massage therapy, although with massage therapy, if you have the diabetic neuropathy, it's quite painful, the massage therapy in your legs and feet. But there's also heat and cold therapy. I quite often have a beanbag around my neck because I have some pain in my neck. And I never did try acupuncture, but that is probably an option. And in terms of mindfulness, I've tried that on and off over the last few years. I use the Calm app, and admittedly not probably as much as I should, but there are some great apps out there to help you with mindfulness. Most of my strategy has been around medication, unfortunately, because I'm at the mild to moderate stage of pain.
Okay, thank you, Dave. Dr. Sikaneta, does any of this resonate what you did in your research scan? Mindfulness, different approaches?
In my research scan, I found, for example, I'm going to read it, quote unquote, effects of live saxophone music. There are a variety of things that have been looked at. I didn't really see anything that jumped out. It's not certainly nothing that has made it to mainstream yet. But what I did see as a theme is the idea of addressing the groups of symptoms that come together. So addressing sleep and restless legs, anxiety, and depression, because they then kind of positively alter the course of pain and of each other. So whether that is all pharmacologic or otherwise, I think the idea that these things kind of go together, they're birds of a feather, and if you can kind of address all of them, or at least try to maintain a holistic approach to it, that will ultimately help with pain as well.
Is chronic itching part of that constellation of symptoms that can be tied to pain as well?
It's been looked at. I didn't see that. So
Okay.
definitely chronic itching it's even more common than pain, and it definitely impacts negatively quality of life. But the ones that I found that were in my review of the literature that were particularly linked to pain were anxiety and especially depression, and to a lesser degree, sleep disturbance. So addressing those might go some way towards helping with pain. And vice versa. Addressing the pain, of course, will help with sleep.
Do we currently, not we, I'm not in the healthcare field, is anxiety and depression well dealt with if we're looking at possibly dealing with a root cause or a conflating factor for pain?
I don't think so. I think that, well, first of all, we don't have an adequate mechanism to pick up pain, as I mentioned, because if half of people have it, we don't have half of, and the resources that are suggested based on the literature when you identify pain would entail this pain ladder. It might entail getting help, like what Lily got, like a multidisciplinary team, like involving a rheumatologist. If 2/3 of the pain is MSK, a rheumatologist might help, or a palliative doctor might help, or in the case of the elderly, geriatrician might help for things like anxiety and depression. So just on the basis of the fact that in our center, which is a pretty big center, we have very few people who would be getting this type of approach, in part because pain is under-recognized, but in part because once it is, we don't have yet a formalized way to try to deal with this. So, and I'm pretty sure this is how it is more broadly. It's not just I think it might be different in the pediatric world. They generally are better than us holistic, I would
Well,
guess.
Okay.
and I do want to add, I make it sound very positive, and it is very positive right now, but she's 6 years into her journey. The wait list for the complex care was 3 years. The getting access to the chronic pain was extremely difficult. I didn't even know it existed. I didn't get access through the hospital. I got access through an external referral. So my therapist suggested that I ring the alarm bells because no one in our house was sleeping related to pain or sleep. We don't know, chicken and egg, right? With the sleep and the pain. But once I rang those alarm bells, a pediatric consultant in the community, I put everybody on the email basically, called us in and he referred us to chronic pain. But again, I believe that was a 1 year to 18-month wait list, which isn't horrible, but access is definitely one of the challenges with managing pain is access and then advocating. I needed someone to push me to say the fact that no one in your house has slept for 3 months is a major issue. So that helped.
Wow.
Okay. Thanks, Kristen. Sorry, Dr. Sikaneta.
No, I was just saying, wow, I bet it makes a lot of sense that having a champion for, like, I think you would be obviously a great advocate, but having a champion in the healthcare profession to make the referrals, to coordinate all get the coverage for the drugs, if there's funding issue, like basically you need someone to quarterback that process. And I know that we definitely don't have that, which considering if this is like half of our patients, it would be, I mean, obviously this would be a resource issue, but it is at the same time very important.
Thanks for that. There were a couple of questions posed as well. One about living with chronic back pain for 20 years and receiving multiple treatments, but really not covering it. We can't really offer direct medical guidance, but I do know one of the other questions around NSAIDs, non-steroidal anti-inflammatory drugs. Dr. Sikaneta, can you explain the reason why those drugs are of note?
Well, they can be effective depending on the type of the pain,
Yeah.
but they're generally avoided in people who have kidney disease, especially those who are not yet on dialysis. They're given a little more commonly in people on dialysis because at that point there's a shift from protecting your kidneys to replacing them with dialysis. So they are given more commonly in the dialysis population than the pre-dialysis population. But NSAIDs are also on that ladder of escalating pain. They're down. They're not the narcotics that are at the higher levels of pain. So they're limited in terms of the amount of pain relief they can provide.
We touched on it a little earlier. I forget who mentioned it, but I heard drain pain. There are different types of pains associated with the different modalities or different stages of kidney disease. If we take, for example, peritoneal dialysis, can anyone explain what is meant by drain pain if you've experienced it or treated it?
I can talk about it. I haven't
That'd be
experienced
great. Yeah.
it. Some patients, when they're, because peritoneal dialysis is the type of dialysis where fluid is instilled into the abdominal space, and that draws out the water and the toxins, and then that gets drained. So then a fresh set of fluid can be put in. And sometimes both on the ingress of the fluid, putting it into the filling pain, and more commonly when draining the pain, there can be abdominal pain. Sorry, draining the fluid, there can be abdominal pain associated with that. And there are strategies to try to mitigate that. For example, sometimes they put pain medicines right into the fluid. Sometimes they just, it's only when you get to the bottom dregs of the fluid that you get the pain. So you don't go that low. You kind of just go a little bit, you keep filled a little bit, and then you replace the fluid. So there are strategies to try and work around that. Anything
Anything
else?
beyond drain pain in PD?
Well,
Aside from potentially cold fluid going into the abdomen?
sometimes the catheter, which is what is needed there's a
Yep.
surgically placed catheter in the abdominal
Yep.
wall to allow the fluid to be put in and to be taken out. And that catheter can get infected. It can get, you can have problems that arise related to the catheter, which can then give rise to pain. And a more dramatic one would be if that infection gets into the abdominal space, then you have a peritonitis. That's pretty dramatic pain. Most of those patients are admitted to hospital.
And very difficult to treat.
And definitely.
Yeah. Dave, I wanted to ask you, in all the peer support groups you've been in and the peer support connections you've made, do people ever ask about dialysis? And what I understand is people always ask, does it hurt to put needles in your arm? Or does it hurt to connect to a machine? What do you hear, if anything at all? What are people concerned about when they're choosing dialysis?
I guess there's a number of things to consider when you're choosing your modality, whether it's peritoneal or hemodialysis, and speaking specifically to hemodialysis because that's what I was on. And what I've heard in the groups, that's the first question. Is not question but comment is, oh, it's going to hurt to inject myself or needle myself every time I have a treatment. And so that fear comes into play. And I hear a lot of complaints about leg cramps, not complaints, but just people mentioning, leg cramp on hemodialysis, specifically leg cramps and headaches from blood pressure changes um, and that sort of access point pain. I had a perm cath in my chest, so I never experienced uh, the fistula installation or having to needle myself. I was always hooked up through the perm cath in my chest. So, but I did experience the leg cramps, the headaches, having to sit after treatment, while your blood pressure recovered. I would still drive myself home, but um, yeah, there's those are mostly the questions I get in the peer support groups. They're, when choosing a form of treatment, do I do it at home? Do I do it in center? Peritoneal because I like to travel and that sort of thing. So there's usually discussions on which way to go, and it's a lifestyle question, I guess you could say. On people like to travel. On peritoneal is probably the best way to go, but some people just want to have it done and go back home, and hemo would be that way. And And then some people are, unlike me, brave and have hemo at home and do it themselves. That just wasn't for me. Although 20 years ago for me, I was brand new. I was just coming on stream. So I had a crash start. So I had jugular vein and, dialysis treatment the same day. So, and then the permacast put in a couple of days later.
Thanks, Dave. Dr. Sikaneta, are these the sort of questions people ask when you're explaining the different options for dialysis? Leg cramps, headaches, accessing a fistula, surgical insertions?
Yeah, they definitely ask those. I think the chief hesitancy I encounter in people making a decision about dialysis is just the fact that they don't want dialysis, period, regardless of the type of dialysis. They're not ready to accept that their kidneys are failing. They feel well, and in fact, the crash start that Dave just talked about happens in. It's what we try to avoid by preparing people for dialysis earlier when they feel well. And yet, paradoxically, because they feel well, it's hard to convince them to, make a drastic change to their lives to go on hemo or peritoneal dialysis. So, but those that are accepting of dialysis and are then faced with the option of, do I do peritoneal or hemo, and which of the hemo ones? Yes, they ask these types of questions and they're concerned about these types of things and different people will be better suited to different types of dialysis. I think that's fair to say. Those that are wishing to be more independent and not be having to come into a hospital 3 days per week for the hemodialysis, but to come much less frequently just for their peritoneal dialysis clinic visits, because they're working, because they have homes to run, they're still raising young kids. They are better suited with one of the home-based treatments options. And conversely, others might not have the ability, they may not have even the facilities, may not have a home, they may be renting a home, can't adjust, they don't have the space or are not able to adjust the plumbing to do any of the home-based treatments. So these are other questions that I get that are playing in the decision of the patients who are approaching dialysis.
Thank you. There was one quick question. Any drugs, medications that would not in fact harm the kidneys? And I gather by that it's meant pain medications. And I know it's impossible to say that one drug is safe for everyone or unsafe for everyone. Are there drugs that have less of an impact on the kidney, or can we venture that far?
So as a rule, the non-steroidal anti-inflammatory meds should be avoided, particularly in the patients with advanced kidney disease who are not yet on dialysis, as a rule. And then the narcotics have to be dealt with carefully because they can accumulate, and there's certain of them that just shouldn't be given at all, like Demerol. But there are others that are safe to give. These don't hurt kidneys. The problem is not that they are going to make your kidneys worse, with the exception of the non-steroidal anti-inflammatories. It's just that the metabolites build up when you have kidney failure. You don't get rid of them the way people whose kidneys work normally do. And when they build up, they can cause more side effects that are not directly, they don't hurt your kidneys, but they build up, and so you can get confusion, nausea, vomiting, constipation, all manner of side effects, which are more likely to happen just because the kidneys are not working.
Okay, thank you for the explanation. I wanted to ask, is it a routine part of clinic visits to discuss pain? Or is it in fact left to the patient to describe it?
It will be now for my clinics, for sure. At minimum. And the other thing I found is that it needn't necessarily be a very detailed and take long, lengthy. It's just, do you have pain? And even and just quantify it on a 0 to 10 scale. That's what a lot of these studies showed. And so then you can use that. That's enough to then change management. It's enough to, based on the level out of 10, you can say, okay, can be treated with Tylenol, or this can be treated with Percocets, or this one, something heavier. And so it's not a routine part. It, I think, should be more. This is what I'm also reading in the literature. And it doesn't mean that it's going to delay things necessarily. Especially if it becomes a habit, it should be smoothly integrated, in my view.
There's a lot to cram into a clinic appointment, and even for people on dialysis, they see the nephrologist. It's a lot to get in there. But I do know in other care environments outside of kidney, symptom assessment or regular symptom interviews when you come to clinic is routine. I'm thinking of cancer care, for example, and I think it's about looking for trends, or is it different than it was last time? And really that's of use, I think. Tracking, is the pain new, perhaps? Is it worse than it was before? What makes it worse? These are all helpful questions, I think.
Yeah, I think there's a lot that we can learn from the cancer literature, because their pain is perhaps even more of a problem. It's not, it can be very significant. And so they're further ahead in terms of treatment, they're further ahead in terms of regularly asking about pain and managing pain. Like this ladder that I'm talking about, it was taken straight from the cancer literature. So the multidisciplinary role, I think, is another thing that people in the cancer field are further ahead than we are. Ask about that, provide that holistic approach.
We've talked about research. What's new and exciting on the horizon for pain management? What can we look to with hope?
I think what I came across are studies that are looking at providing holistic approaches. They would randomize people, for example, groups of patients they receive a holistic approach. First, they have to get that screening that we're talking about. They have to uncover the pain, quantify the pain, and then they will provide education and other holistic methods of dealing with the pain versus the standard of care and showing benefits. So that's one thing. And then there are always new drugs that are being developed that are possibly less toxic and just as or more effective than the existing ones. So the pharmaceutical field is moving as well. But I would say it's a matter of increasing the awareness, is what I'm seeing in the literature, is what is leading. Because a lot of cases of pain that I read in literature, once it's identified, and once you apply something like this WHO ladder, the algorithmic approach to pain, is effective in the majority of cases. So like a 90+% reduction in pain, resulting not because of some newfangled drug or some newfangled technique, is just asking about it, quantifying it, and applying some, algorithm to that pain. So I think awareness is really the increasing awareness is what I'm learning is the biggest bang for the buck.
It's just that simple. Kristin, I wanted to ask you, given your experience with Lily, would you have done anything differently? I mean, if you were talking to a parent of a child or someone living with kidney disease, what do you wish you had asked earlier, or investigated, or advocated for, or took it upon yourself to learn? Does anything come to mind?
Yes, there's a few things I would have advocated earlier on, and they were just hinted upon too. The multidisciplinary approach, I would have definitely advocated for sooner. We also did a few times now have met as a multidisciplinary team where a few of her specialists would meet together. So nephrology, neurology, chronic pain, and patient representative would sit down together and discuss a plan for the pain. We've had similar for like infections, where multiple clinics will sit down to discuss ongoing infections. So the same model was kind of approached with the pain. And that was quite helpful because there was a lot of just varying streams of like, we're working with the kidney, we're working with the legs, we're working with the head pain. And by putting everybody together in the same room, there was a much bigger overall approach.
Is that hard to do, to get everyone to get in the
Yes.
same room yep.
Yes. Or everybody on the same Zoom. Yes.
Yeah.
Having complex care, which I've been told doesn't exist in the adult world, which I'm really not looking forward to. Having a model like the complex care model does give you access to a team that works with all of the specialists. So that really, really helps, is having that overarching team kind of bring everybody together and facilitate these meetings. In the early days, it was actually a nurse that approached me bedside and basically could tell by the amount of questions I had. And at our hospital, nephrology pediatric patients are on the same floor as oncology patients. And that did work in our favor because the nurse knew that families could ask for team meetings. And she knew that because the oncology families frequently had team meetings. So she came up to me and said, I think a team meeting about kind of the next steps. Again, she was in hospital for 3 months. So what are the next steps? What are the plans? You know, is she going to be in dialysis? How are we approaching this pain when we get home? Having all those questions. Now that meeting took quite a while to organize, probably weeks, but it was a very, very integral part of our discharge process. That meeting needed to happen before she was discharged, and it did.
Yeah, I'm mindful too, Lily at some point will transition to adult care. Yeah, and I know you're worried too, the difference between what is provided to children versus adults, but it's at least a little promising that Dr. Sikaneta is looking to change the pain world in the kidney perspective, no?
Yes, and I think there's some
Yeah.
positives as well to that
Yeah.
transition in the fact that right now I feel like some of her doctors, although they're all wonderful, I have nothing negative to say, they're all great, but I think sometimes their exposure to like a client base in the adult world is going to be larger, and there's going to be a larger team of nephrologists or doctors working together just because they have a larger base, at least in a big city. And I think that that will be a definite benefit, that she may be able to get like specifically linked to a nephrologist who has experience with pain or a nephrologist who has experience with her. I think part of Lily's maybe missing piece is I do believe that her diagnosis of FSGS is likely related to the pain to some degree. So maybe seeing a nephrologist with more experience with FSGS will be a benefit in the adult world. So I do still think there's some definite positives. Of course, there's some trepidation about the change, but that doesn't mean that I really see it as a negative. I don't. It'll just be a transition.
And you know a lot more than you did years ago, right?
Yes.
Yeah.
As long as she allows me to transition with her, right?
Yeah. Dave, I wanted to ask you the same question in terms of managing your own pain. Is there anything you would have done differently about educating yourself or posing questions to your care team or changing habits and lifestyle? Do you ever look back and think I would do things differently? And does that inform what you tell people in peer support groups about how you encourage them to approach pain?
Um, I think for me, um, maybe starting a little earlier in becoming an advocate for myself in terms of advocating for um, my health care from see, part of the problem I've always found myself, and it might just be me, but um, is I get an ailment, pain, an ache, a sniffle, or whatever, and who do I call? Do I call my family doctor? Do I call my transplant team? Do I call my nurse practitioner? And sometimes I go to my transplant team with an issue, and they say, "Oh, well, next time you just go to your family doctor for that." And so stuff gets lost in the cracks. So Um, I think hopefully to answer your question, is to always consult your healthcare provider before starting any pain treatment or any treatment at all, because CKD patient is at higher risk for side effects and drug interactions. Same as when you've had a transplant, you're on so many different meds, and I think I would get a best friend in someone like a pharmacist in your back pocket so that you can consult on a regular basis when somebody talks about drugs. Educate yourself, advocate yourself, monitor your kidney function better, medication adjustments. It's all essential to ensure your safety and effectiveness of your treatment, and also take part in some of the support groups that we've talked about, Kidney Foundation, because we could go on for days in a short period. We only have a short period of time here, but these Kidney Foundation peer support groups, there's so many shared experiences. Every time I go to facilitate a meeting or go to a meeting, I learn more and more about, maybe what I should have done differently, and you learn from others' mistakes. So that would be something I would advise people to do in the future. If I
Thanks for
got it all, sorry, go ahead.
No, thanks for putting the plug in, Dave. I appreciate that. And certainly these are the conversations that happen. A phone call to the foundation, meeting in clinic, a casual email. People are concerned about pain. It's hard enough living with kidney disease, but unmanaged pain or unmanaged symptoms. I suspect having an integrated care team that talks to one another, like Kristin suggested, and Dr. Sikaneta acknowledged as well. I hope, if nothing else, people understand that it's fair to ask these questions. It's appropriate to, look at your pain critically. When does it happen? How would I describe it? What's the intensity? All these tools exist, but and knowing that the person you ask the question of may not be the one who can give the answer, but they can direct you where it needs to go. Dr. Sikaneta, one last thought from you. Anything in this conversation surprise you? Anything Dave or Kristin said, or any of the questions? Not sure what you're expecting in the discussion, but what are your thoughts?
Well, I was it really jived with what I had read. For example, what Kristin talked about, where it wasn't a nephrologist that identified or was maximally effective with helping with her pain. That jived with the literature, with what Dave said, the persistence of the neuropathic pain, that kind of fits. I was surprised, and it makes me think, as I had said earlier, about the improvement of the pain with a transplant, because the thinking is that only a small proportion of pain can be directly attributable to the kidney disease or to the dialysis process itself. But the fact that the neuropathic neuropathic pain persisted, but the musculoskeletal pains improved, that was a surprise, and makes you go,
Okay, that's helpful. We've come to the end. I really quickly want to go through some last points. The Kidney Foundation, first of all, thanks to the panelists, Kristin, Dave, and Dr. Sikaneta, for being open and frank about your thoughts and lived experience. I want to remind everyone that the Kidney Foundation is there for you in many ways. To request one-to-one peer support, you can fill out the online form or call 1-866-390-7337. You can register for any of the 22 monthly virtual support groups at email peersupport@kidney.ca. You can connect online with others with lived experience. Visit kidneyconnect.ca. And for information to support you in your kidney journey, please visit our sites, kidneyinfo.ca and kidney.ca. That's a lot of .cas. But lastly, thank you everyone for participating in this session. We invite you. Thank you again.